So I think the most common topic is ovulation induction. At the same time, the most important thing for any consultant who is practicing infertility and any gynec, basic whoever is treating a basic infertility patients, ovulation induction is the most important thing which we all should master in. So I think today probably I'll try to give some practical tips in improving your success rates through ovulation induction. So generally, we all know, for pregnancy we need to have a proper ovulation and the production of a healthy egg. Here, the emphasis is on healthy oocyte and enough healthy sperm being produced, and the ability of egg to travel through the tubes to reach the sperm, and sperm being able to travel through the cervix to reach the egg. These are the most minimum things which we require: a proper ovulation, healthy egg, healthy sperm. The most important thing. Healthy gametes are important, and along with the patent tubes. So, and also the sperm's ability to fertilize the egg, a fertilized egg becoming a healthy embryo, successful implantation of the embryo in the uterus. Here again, the whole emphasis on producing one healthy egg and a healthy sperm. So, whatever ovulation induction we are giving, we are aiming at a quality, not at the quantity of the follicles. See, our aim should be not producing multiple follicles, whether it is ovulation induction for timed intercourse or IUI. Our aim should always be producing the healthy quality oocyte. So for that, whatever drugs we can use or whatever protocols we can use, we have to try so that the pregnancy rates will be much better. So before going for any procedure, we have few prerequisites which we always should keep in our mind. Taking a proper history, as I always emphasize on taking a proper history, which almost gives 80% of our diagnosis, and also what treatment we have to go for that patient. Taking a detailed menstrual history and the previous treatment history. The most important is, as in our center we get a lot of patients, referral patients, who they have already taken a lot of treatments outside. So taking a detailed proper previous treatment history will give you so much of information how to proceed in the induct cycle. So taking a proper history is very important. And sometimes treating hypothyroidism, we all know that hyperprolactinemia and hypothyroidism is one of the most common cause of anovulatory disorders. Sometimes treating those disorders will also give a proper very good quality oocyte in pregnancies. So that's the importance of taking a proper history, and especially taking a proper previous treatment history, what are the treatment the couple has undergone. And obviously, before starting any treatment, we have to assess the pelvic pathology. A basic scan is very important to evaluate the ovaries, ovarian reserve, and also the see the uterus, any lesions in the uterus like fibroids, or how is the endometrium, assessment of a pelvic pathology, ovarian reserve, and hormonal status. The minimum things we do is a thyroid profile and a prolactin. Day 2 hormones not necessary in all the cases, but yeah, that will give a added idea about how to go in the treatment in the index cycle. Tubal status, yes, if definitely you have to rule out tubal patency if you're considering IUI. And the most important is a semen analysis. Without a semen analysis, never ever touch a patient, because now the male infertility is on raise. Almost 50% of the patients now we are seeing are male factor patients. And after evaluating all these things, you need to counsel the patient that this is the treatment we are opting for, this is the treatment we are planning for you, and these are the minimum cycles required, and these are the success rates for this procedure, and the importance of follicular monitoring, that they need to come for regular follicular monitoring and require injectable gonadotropins if necessary. And we should always counsel the minimum number of cycles required or advised in that couple. So, generally, what we do, if a woman has regular periods, engaged, less than 30 years, infrequent intercourse, obviously, we have to advise about the regular intercourse at least thrice a week, and review after a certain period. But nowadays, because of the work schedules, all the shifts, actually, couples are not having a regular intercourse. So advising them regarding the frequency also will improve the will might give them results. So counseling is very very important. And if the even though there is a regular intercourse, still there is no pregnancy, we can always wait for at least 1 year before planning any treatments. So, but in certain cases, these rules don't apply. When does the rules don't apply? That means we have to investigate the couple if the woman is more than 35 years. Even though they are married for 6 months, they're trying for 6 months, still there is no pregnancy. It's better we intervene, evaluate the couple, and plan accordingly. So, if woman is more than 35 years, tried for more than 6 months, if the woman is having irregular periods, that means that we know that she needs some assistance for her ovulation, or if there are any ejaculatory failure or sexual dysfunction in the male, yes, definitely that need to be treated. So these are the cases where we have to intervene early. When it comes to the regular investigations before starting our ovulation induction, the minimum thing is we have to do a baseline scan on day 2 to rule out uterine pathology, to assess the ovarian reserve of the female, to count the AFC, and so this gives an important information how to go about the treatment. And also day 2 hormones like FSH, LH, estradiol, thyroid and prolactin, and routines like CBP and RBS. We all know that the general health of the female is also important to produce a good quality oocyte. Here again, emphasis on the good quality. Obviously, if the hemoglobin everything is not up to the mark, obviously quality of oocyte will not be very good. Whenever you woman is complaining of irregular cycles, yes, you can add GTT. I generally don't do all these androgen profiles or fasting insulin, all those things. If you are seeing a grossly hirsutism, all these investigations, what we do in PCO are to rule out the other causes of hyperandrogenism. If you are seeing a significant gross hyperandrogenism, then you can do all the other androgen profiles to rule out the other causes of hyperandrogenism like Cushing's or any androgen producing tumors or something. Otherwise, routinely they are not important. But about AMH also, if your scan is, you're confident about your scan that the scan is showing a good ovarian reserve, everything being normal, young patient, generally I don't do AMH in all those cases. But if I see a woman with low volume ovaries or low AFC, elderly female, yet definitely AMH is a very important investigation which helps in counseling the patient apart from giving a idea about a treatment, but it helps in the counseling of the patient. And what treatment we can plan, uh, uh, we can always get an idea with our AMH level. So yes, definitely AMH is required in required investigation in elderly female, or if any female with a low ovarian reserve or low volume ovaries. Some a few points on semen analysis. Yes, in detailed semen analysis is very very important. That itself gives you an idea what treatment we have to go in that couple. We all know the minimum concentration is 15 million with 32% motility and 4% morphology. The counts are around 10 to 15 with low motility. Definitely, the treatment option will be IUI, and we all know the option is exceed the counts are less than 5 million with very poor morphology and motility. So after evaluating the couple, after going through a proper history, after doing the minimum basic investigations, then we have to decide who needs treatment, whether and what treatment the couple needs, whether it's a normal ovulation induction with timed intercourse, or the patient couple needs ovulation induction with IUI, or the patients are directly for IVF or ICSI. So then we have to decide what treatment we are planning for them. Then we have to discuss with them the success rates, again the need for follicular monitoring, may need injectables in cases like PCO, or previously they already had ovulation inductions with oral agents but no response. You need to explain them that they will need injectables, plan the treatment, and importantly the number of cycles might required for them and the cost involved with each cycle. So now coming to the proper topic of ovulatory dysfunction, 40% the causes of female factor infertility are ovulatory disorders. We all know the hypothalamo pituitary ovarian axis. The gonadotropin releasing hormone is released from hypothalamus, which acts on pituitary. FSH and LH acts on ovary and produces estrogen and progesterone. So when the levels of estrogen and progesterone are low, it gives a positive effect on the hypothalamus, and again it secretes the GnRH hormone. This is a normal mechanism which we all know. So the regular menstrual cycles are around 22 to 35 days. So this is regulated through complex feedback mechanisms with the hypothalamo pituitary ovarian axis. And what are the other conditions which might affect this axis? Yes, the thyroid dysfunction, hyperprolactinemia, and polycystic ovarian syndrome. These three disorders will affect this hypothalamo pituitary axis. So the first thing we do is to we rule out thyroid and also hyperprolactinemia. So there are two types of ovulation induction. There are two general treatment strategies that focus on ovulation. The first one is ovulation induction. Ovulation induction is pursued in patients who are not ovulating. That means they are having anovulatory cycles, most commonly like PCO cases. But controlled ovarian stimulation is a terminology where we use when the women have a ovulatory cycles but experiencing infertility. That means they are ovulating regularly but they are not conceiving. This is in these cases the terminology used is controlled ovarian stimulation. Both treatments incorporates many of the same almost same medications. So, ovulation induction, anovulatory women with adequate ovarian reserve and no other treatable causes are candidates for ovulation induction. It generally mimics the hormonal pattern of the normal menstrual cycle, which we have discussed now. So, from anterior pituitary, FSH and LH are released, which acts on the ovary. We all know the changes which happen. The first half is predominantly FSH dominated, where estrogen is secreted from the growing follicle, and after at around 18 to 20 ovulation happens, then the progesterone predominates in the corpus luteum and pregnancy or the degenerating corpus luteum. This all we know that the proliferative phase is mostly dominated by the FSH and estrogen, and the secretory phase is mostly by the LH and progesterone. So what is the goal of ovulation induction? The goal of ovulation induction is always development of a single dominant follicle. So whenever we are giving our induction, our aim should always be a single follicle with good quality. So when can we add IUI to our ovulation induction? IUI can be done even when semen is normal. We already know the indication for IUI is one is male factor when the counts are less and motility is less. But we also do IUI when semen is normal in cases of unexplained infertility, ovulatory but tried for timed intercourse for at least 3 cycles, anovulatory responded to ovulation induction for 6 cycles but not conceived. These are the cases in which IUI is often combined with a hyperstimulation to increase the number of available oocytes and also to increase the possibility of conception. So basically, we all know that ovulation induction, anovulatory disorders are classified into 3 categories according to WHO. The WHO category 1 is hypothalamic pituitary failure, that is hypogonadotropic hypogonadism, where both all the hormones are less, FSH and LH, and all are less. The most common conditions are Kallmann, Sheehan's, anorexia. In this group, the gonadotropin of choice is HMG. This needs both FSH and LH to stimulate the ovary. The second most common group, and 80% of the ovulatory disorders fall in this category, that is PCO, hypothalamic pituitary dysfunction. And the third one is ovulatory failure, where it is a hypergonadotropic hypogonadism. That means the ovary has failed, the FSH and LH are very high. There is very poor response to our ovarian stimulation. Most common conditions are Turner's, autoimmune, mumps, radiotherapy, chemotherapy. All these conditions fall in the category 3. These, most of them go with the donor oocytes in our IVF cycles. So basically, what are the drugs we have for ovarian stimulation? We have very few drugs. So we have to use the combination of these drugs to to our stimulation protocols to improve our success rates. The most common thing is clomiphene citrate and tamoxifen. These are selective estrogen receptor modulators, aromatase inhibitors, letrozole, anastrozole, and the other injectables, gonadotropins, where we have HMG and highly purified FSH and recombinant FSH. And there is one more drug which we are of late using it in our normal ovarian stimulations and IUIs as well, which is GnRH antagonist. So we'll quickly go into each one of the drugs. The most common drug used is clomiphene citrate. It's simple to use, it has minimal side effects, and it's very cost effective. Treatment with CC resulted in ovulation with 70 to 80%, and only 40% of these women conceived, and 5% have multiple pregnancy and OHSS. We all know the mechanism of CC. It is a selective estrogen receptor modulator which blocks estrogen receptors at hypothalamus, which gives us pseudo low estrogen levels, which stimulate the hypothalamus, secretes FSH, and gives multifollicular development. At the same time, it blocks estrogen receptors at the cervix, endometrium, and vagina. So in some cases of CC stimulated women, we see thin endometrium. This is because of the blocking effect of estrogen receptors in the endometrium, vagina, and cervix as well. So what is the dose we generally give? The minimum dose we give is 50, but nowadays 50 we are not using. We are starting with 100 milligrams only. So always give single dose together. That means if you want to give 50, two tablets also give together. Single dose together. Always monitor the cycle with ultrasound. Never give CC and ask them to have intercourse during day 10 to day 18, and later give progesterone and ask them to come if they miss period or something. Don't never ever do that. You should always monitor the cycle with ultrasound. If ovulation is confirmed with that dose, you can maintain the same dose. Otherwise, the maximum dose we can give of CC is 150 milligrams per day. So there are few side effects with CC because of the vasomotor flashes, mood swings, visual disturbances, which are very rare, breast discomfort and pelvic discomfort, nausea. These are the few side effects. There are two terminologies which we should understand. One is CC failure. That means there is ovulation with clomiphene citrate, but there is no pregnancy. And there is CC resistance. That means with the maximum dose of CC also there is no ovulation. That is called CC resistance. These are the cases where we need to counsel the patient for either CC plus gonadotropins or going for a total gonadotropin cycles. As I told you, CC has anti-estrogenic effect on cervix and endometrium, where it may cause thin endometrium as well as poor cervical mucus. What we can do in these cases is you can start early CC. That means day 1 or 2 itself you can start CC, and also you can add estradiol valerate from day 8 or 9. That means once the dominant follicles you see, that means at least 14 mm, then you can add estrogen estradiol valerate from day 8 or 9. Or the other last option is you have to change the drug. Either you can try letrozole or you can go for a total gonadotropin cycles. Few practical tips of CC. There is no particular rule that you have to start CC on day 2 or day 3 only. You can start any day of the like day 2, 3, 4, 5, makes no difference. Dose 50 milligram per day, you can raise by 50 if there is no ovulation. The maximum dose we can give is 150. In cases of PCO, where the endometrium is very thin, there is no withdrawal bleed also, we can also start CC. And there is no need that she should have a withdrawal bleed to start CC. If the endometrium is very thin and there is no cyst in the ovary, you can always start with CC even though there is no menstrual cycle. So when to stop when you're starting, we should also know when to stop the drug and change your protocol. When 6 ovulatory cycles fail to yield a pregnancy, you need to stop giving CC, or there is no ovulation with maximum dose of 150, or if the endometrium is persistently thin, less than 7 mm at the time of ovulation, this is the time we have to stop CC and change the drug and go for a different protocol. There's one more very interesting protocol with CC. It is called a stay-step protocol. This is mostly for the PCO cases where you can start with CC 50 milligrams, do a scan on day 7, and again, if there is no dominant follicle, you can again increase to 100 milligrams, give five more days, and do the scan after 5 days and see if there is still no follicle, you can increase the maximum dose to 150 in the same cycle. That means the maximum 150 milligram per day dose of CC can be reached. That means you are giving the maximum dose in a single cycle. Even though it's a prolonged stimulation, you will know that what is the maximum dose of CC required to have ovulation, so that the patient cycles won't be wasted. That means whatever treatment we are trying to give in 3 cycles, we can have an idea in the single cycle itself. It's mostly for PCO cases where you can use this step protocol. Next comes the aromatase inhibitors. The most common aromatase inhibitor which we use is letrozole and anastrozole. Aromatase is an enzyme we all know that converts androstenedione to estrone. That means androgens to estrogen. So testosterone to estradiol. So what does aromatase inhibitor does? It reduces the systemic estrogen levels in the ovary. It increases the gonadotropin secretion, follicular development, and ovulation. This is a mechanism. We all know that testosterone and is converts to estradiol by aromatase enzyme. This blocks this enzyme so that it produces low levels of estrogen, which stimulates the pituitary and produces more levels of FSH. So the recommended, we can CC letrozole, we can start with 2.5 milligrams. The maximum you can give is 7.5 milligrams per day. But generally, I start with 5 milligrams per day. And anastrozole is 1 milligram per day. There is a reduced incidence of multiple pregnancies compared with clomiphene citrate because of the development of few follicles in CC with letrozole. Pregnancy rates with letrozole appear to be similar with clomiphene citrate. So what are the few things which we need to know about letrozole? Aromatase inhibitors do not affect the cervical mucus or endometrial development, but there are no improved pregnancy outcomes in clinical studies. Initial concerns about the teratogenic potential is there, but now it was ruled out, and in fact, ISHRA has come up that letrozole is the first line of therapy in cases with PCO. Yeah. So there are few more protocols with letrozole. One is giving from day 3 to day 7 of menstrual cycle, which we routinely follow. Other thing is you can always give letrozole in a increasing doses. That means from day 2 you give single tablet, day 3 2 tablets, day 3 3 tablets, day 4 4 tablets. The maximum dose again you give is 10 tablets. So that is one more protocol which we can use. And the other one is giving a single dose of 20 milligram letrozole on day 3, which I didn't use this protocol, but I have used in this day 2 1 tablet, day 3 2 tablets, day 3 3, like that, increasing doses of till 4 tablets per day. That I used with a very good result. And the other is like same like CC, where you can start with 2.5 milligrams and do a scan after 1 week and see there is no follicular development. You can increase to 5 milligrams in the same cycle to maximum of 7.5 milligrams in the same cycle. These all protocols are mostly for PCO cases. So we have discussed about clomiphene citrate, letrozole, anastrozole. Next comes, after oral drugs for ovulation induction, next comes the gonadotropins. The indication for gonadotropin are CC resistance and CC failure, and actually WHO category 1, where there is hypogonadotropic hypogonadism. What are the protocols with gonadotropin? We have one protocol where we can use a combination of CC plus gonadotropin. So what is the advantage of this protocol? In fact, there are no studies using this combination, but this protocol will definitely reduce the total dose of gonadotropin used and reduces the cost to the patient. Concurrent use of CC plus gonadotropin allows follicular development to a desired extent, and endometrium is not adversely affected, and OHSS is less common and cost is less. So this is a protocol which we use generally from day 2 to day 6 you give. So you do a day 2 scan, see for any cyst are there or not, and then you start CC from day 2 to day 6 you CC, and then do a day 7 scan, see whether there is a follicular dominant follicle or not. You can add gonadotropins day 7, 8, 9. Again do a scan on day 10. Depending on that, you continue gonadotropin or give trigger depending on the follicular size. If the follicle reaches 18 mm, then you can give a HCG trigger. You should always monitor using ultrasound. So how to use injectable gonadotropins and what to expect? So what gonadotropin we have to use for what patients? This is the most common question a lot of people ask, whether we have to give HMG or FSH. To be frank, my results are almost same with both recombinant FSH and HMG. Definitely the patient is elderly, couple is female is elderly, I try to, my choice will always be HMG. Mostly I use recombinant FSH for PCO patients. So, if the LH is very high in cases of PCO, it's better you go for FSH. Otherwise, in group 1, obviously the drug of choice is HMG. But if the patient is elderly, age more than 35 years, it's better we go with HMG. How to decide the dose of gonadotropins? The dose of gonadotropin we can decide depending on the BMI, assessing the ovarian reserve, as I told you, age of the female, what is the cause of infertility, and the dose needed in previous cycle. The previous treatment history gives you a lot of information how to go in the index cycle. Depending on these factors, we decide the dose of gonadotropin. Points to be considered, we should always do a scan on day 2 before starting a stimulation. Endometrium should be shut properly and there should not be any cyst. So whenever you are using a total gonadotropin cycle, we have to be very patient. We need to counsel the patient that it may take longer days, it may take 10 days or more for a dominant follicle to appear during the first treatment cycle with low dose gonadotropins. This we have to counsel them. What are the complications for total gonadotropin cycles? The most common is multifetal pregnancy and OHSS. So, how can we prevent this complication? By monitoring, strict monitoring of the cycle, and by our previous experience and following a strict protocols. So these are the n number of protocols we have for our ovulation induction, time intercourse and IUI cycles, where we can only use CC only protocol, or a combination of CC with FSH or HMG. Only gonadotropins, where you can go with a conventional regime or low dose step up protocol or step down protocol. And the last but not the least is gonadotropin with antagonist. We all know CC only protocol. We start CC day 2 to day 6, day 7, do a scan on day 10, follow the follicle. Once it reaches 20 we give a trigger and then plan whether termed intercourse or IUI accordingly. This is CC plus gonadotropin, where you give CC for day 2 to day 6 and add gonadotropin day 7, 8, 9, do a scan on day 10. Depending on the follicular size, you continue the gonadotropin stimulation, give trigger at 18 and then plan your treatment, whether a TI or IUI. These are the gonadotropin regimes we follow for our IUIs or timed intercourse. When we need to go for total gonadotropin cycles, you always chronic low dose protocol, where we start with very low doses like 37.5 IU minimum. As I told you, at least you have to give 5 to 6 days to see a small dominant follicle to emerge. So we have to be very patient, need to counsel the patient regarding this, that they might require a longer dose of stimulation. You start with 37.5, increase accordingly. Step down, where we start with a higher dose of 150 and then step down when the follicle reaches 10 Conventional regime, where you give a continuous dose of same international units daily. But definitely low dose protocols are always better. Whenever you're starting, initially it's always better with low dose, and then that will give you an idea how to go about in the next cycle if that didn't work out. So one more in monofollicular development, there is a paradigm shift from clomiphene citrate to gonadotropin. Now the studies are saying that whether it is a timed intercourse or the IUI cycle, is always the results are much better when you are going for a total gonadotropin cycles. CC versus low dose FSH for treatment of infertile women with PCO, randomized multinational study. They say that it has said that pregnancies and live births are achieved more effectively and faster after ovulation induction with low dose FSH than with CC. The results has to be balanced by convenience and cost in favor of CC. FSH may be an appropriate first-line treatment for some women with PCO and anovulatory infertility, particularly older patients. So now all the studies are in favor of going for total gonadotropin stimulations. So these are the results of the study, which again showed that the cumulative pregnancy rates and the live birth rates are matched with total gonadotropin cycles. This is a moving Lancet study which was presented in Lancet December 2017, where they have the inclusion study criteria is age more than 18 years, type 2 anovulation, WHO, 6 ovulatory cycles with CC. And the exclusion are the other pathologies, like if they are having tubal factor or other issues, they are not taken into the study. After taking the informed consent, they have randomized into 4 groups. One is CC with coitus timed intercourse, CC plus IUI, gonadotropins plus timed intercourse, and gonadotropins per and IUI. So, what are the criteria they have taken is the birth of a healthy child, and the secondary outcomes are multiple pregnancies and clinical pregnancy, ongoing pregnancy, ovulation, and cause. So, the result of the study are like gonadotropin group had more live births than clomiphene citrate group. Addition of IUI did not increase live births compared with intercourse. But we have to always think about the cost in our Indian scenario, because going for a total gonadotropin cycle will give a will be very costly for our patients. So definitely we have to weigh the cost, and then depending on the we have to individualize our treatment protocols. Reverse HMG-CC. This is one of the interesting protocol which have come up in fertility sterility, which I didn't use yet, but this protocol where they are saying to reduce the cost of HMG or the number of injections of HMG, what they're doing is they're starting with HMG for 4 days. That means they start from 75 U of HMG from day 3 to day 7. And after that, they are shifting to CC. That means initial reverse. Initially, we used to give CC, then followed by HMG. But here, they're starting with HMG and then shifting over to CC, 150 milligram CC. And this reduces the cost of gonadotropins and the dose of gonadotropin which is required, which might be helpful for the patient. This is a reverse protocol. Uh, again, they have compared this protocol with a control group where they have given only HMG, and here HMG plus CC. In both groups, they did folliculometry, HCG when follicle reaches 18 mm. They have measured serum LH, IUI and all, gave the luteal support and all. So the results are again in favoring with HMG and CC, where the clinical pregnancy rates are better than almost comparable with the total gonadotropin cycle. So there is a clear evidence that justify shift from CC to gonadotropin low dose for ovulation induction. HMG for 4 days followed by CC seems to be cost-effective regimen. So this is all about the ovulation induction in our timely intercourse and IUI cycles. We'll quickly go into some protocols in our ART cycles as well. So as we all know, the number of cycles of ART are increasing drastically, and what we all know that the steps which we follow in our IVF cycle. First, we do a pituitary desensitization, then we stimulate the ovary, that is called controlled ovarian hyperstimulation. Then comes the triggering with the HCG. Then we do oocyte pickup, fertilization, culturing of embryos, embryo transfer, and the luteal support. These are the steps which follow in our IVF cycles. So we are going to talk about ovarian stimulation now. So the ideal ovarian stimulation hyperstimulation protocol should improve our pregnancy rates and reduces the complications like OHSs, and we should also consider the financial status of patients. So which protocol we have to use, which gonadotropin, or is there any room of innovations, we are going to discuss now. Regarding the protocols, we all know that there is two agents which can desensitize the pituitary. That means which can prevent the premature LS surge. One is an agonist and an antagonist. Most of the protocols are with previously they used to use agonist, but now antagonist has come, which is more patient friendly and less complicated than the agonist protocol. So whenever you are using a agonist, they are in these number of combinations we can use. One is a ultra long, that means you are giving depot of GnRH agonist for 3 months prior to our IVF, reducing, desensitizing the pituitary, and then starting the stimulation. This is mostly done in cases of severe endometriosis, but I don't think now anybody is using this protocol. Long protocol is where you are starting the agonist in the previous menstrual cycle, that with day 21 of the previous menstrual cycle, and once the withdrawal, once you get the withdrawal, you're reducing the dose of agonist and starting of stimulation. Um, then is a short protocol where you are starting the GnRH agonist from day 1 of the menstrual cycle and start stimulating from day 3. Ultra short, where you give only agonist for the initial 3 days and then start the gonadotropin stimulation. Ultra short protocol is mostly in cases of poor ovarian reserve, where you need the initial flare effect of the agonist, which might increase the what is the agonist does initially, it flare up, that means increases the FSH and LH stimulation, so that recruitment will be more. This is the concept where we use in like poor ovarian reserve patients, where we need to have a more follicular recruitment. In those cases, you can go for a ultra short agonist protocol. Basically, these are the protocols which we go with agonist. As I already mentioned you, long agonist, we start from day 21 of the previous cycle. Once the period comes, we reduce the dose of agonist and start stimulating. What is the agonist we have? We have triptorelin and leuprolide. These are the available doses: 3.75, that is a depot, 11.25 is for 3-month depot, and 0.1 milligram. And leuprolide, you get a solution, while 0.1 milligram, 1 milligram for 1 ml. And when it comes to antagonists, we have two antagonists. One is citrullinix and ganirelix, which is commonly known as olgoretron. So, as I already discussed about the agonist protocol, now it comes to antagonist protocol, which is my favorite and most patient friendly protocol, where you start stimulating from day to do a baseline scan, rule of the cyst, everything. As after that, you start the stimulation. Once the follicle reaches 12 to 14 you start the antagonist. You should be around day 5 to 6, not more than that. Don't delay the starting of antagonist. Even though the follicular sizes are a bit less, it's better you start from day 5 to 6 of your, excuse me, your stimulation. Then monitor, and obviously we do the pickup, and rest is same. So agonist versus antagonist, the studies say that obviously there are better pregnancies with agonist, but almost it is comparable with antagonist protocols. Generally, most centers now are going for freeze-all cycles. In our center, it's almost like almost 99% freeze-all cycles. When you are planning the fresh transfer, they say that agonist protocols are much better. Almost ongoing pregnancy rates are almost comparable, and there is a significantly lower incidence of OHSs with your antagonist protocol. So basically, there is no statistically significant difference in live birth rate and ongoing pregnancy rate. In fact, there is a slight lower incidence of OHSs with antagonist protocols. So then once we have decided which protocol, whether it is an agonist or antagonist, then we have to think about what gonadotropin we have to use. So we have basically HMG, purified FSH, and recombinant FSH. Generally, we start with a dose of 150 to 225 international units. Depending on the response, we further increase the dose. There are so many nanograms on how much dose we have to start with and all, but it always comes with your experience. Once you start stimulating, then depending on that, you automatically, I think, will understand what's the minimum dose required and all. So yeah, according to me, in my cases in IVF stimulation, as I told you, if it is a case of PCO, I definitely go with recombinant FSH. Otherwise, almost in all other cases, I go with HMG, because we are doing, it reduces the cost for the patient as well, and almost the results are almost same with recombinant and HMG in our center. So yeah, especially in elderly patients, they need a bit of LH activity. There are few studies which have come up that LH polymorphism. Lot of centers, I think Merck has sponsored that study of LH polymorphism. But the result, if I see, it's surprising that 80% of the patients require LH with that study. So I feel that HMG is a better choice, especially when in non-PCO and LLE female patients for your ovarian stimulation. The same thing. What are the few innovations is like previously we always used to trigger with HCG. The most important advantage of antagonist is like when you can always trigger with a GnRH agonist protocol. Agonist trigger you can give. It's the same mechanism. It has a flare effect which increases the LH and gives LH surge and trigger the final oocyte maturation. So whenever you the advantage of using GnRH agonist as your trigger is to reduce the severe OHSS, can be used only in antagonist cycles. It works for 48 hours max. HCG works for almost 8 to 10 days, where there is a risk of secondary OHSS as well. So yeah, is it then it comes the question, if it is safer, why not apply for all cases? But whenever you are using an agonist trigger, the ongoing pregnancy rates are less. So that's the reason whenever we are using an agonist trigger, we always go for a frozen embryo transfer cycles. We don't transfer in the same cycles. So it gives a 10% lower clinical pregnancy rate whenever you're transferring the same cycle, and the luteal support also should be more whenever you're giving a agonist trigger when comparative to HSV. So HCG. So definitely that's the reason we always go with a all freeze protocol whenever we are using a agonist trigger. Few points about dopamine agonist for prevention of OHSS. We all know that dopamine agonists reduce the amount of ascites hemoconcentration and reduces severe OHSS. There is one new drug in trial which I didn't use, quinagolide, the prevention of early ovarian hyperstimulation syndrome. It is a non-ergot derived dopamine agonist. I have no personal experience. And the other innovation is a choriofolitropin alpha. This is a long-acting FSH. It is under the name of Ilonva. It should be given as a single shot, not self-administered, not cheaper. But what are the disadvantages? There are no dose adjustment we can give. It's given as a single shot. Once given, cannot be withdrawn. It is not suitable for mild or monofollicular stimulations, and it is absolutely contraindicated in PCO. I don't have any personal experience with this single dose of FSH. Um, so might be the future might be giving a depot GnRH agonist or long acting FSH. Don't have any idea. And one more interesting thing which I've read during when I'm preparing for this is like high dose FSH at HCG triggering. I never used this, but it's a novel concept where they have given 4 ampoules high dose of FSH at the time of HCG injection. They have seen a 10% increase in pregnancy rates. No much studies and no clinical data. In poor responders, especially antagonist is the preferred protocol. In a primer study 2017, mild versus conventional ovarian stimulation for IVF treatment in women with poor ovarian response, where they have taken 394 couples with a one in the antagonist protocol and one for the conventional long agonist protocol. They have seen that the outcomes are the main ongoing pregnancy rate, and the secondary outcomes are the clinical pregnancy, biochemical. All these things are the secondary outcomes. They have seen they've seen that the almost the ongoing pregnancy rates and clinical pregnancy rates, biochemical pregnancy almost are same with a mild ovarian stimulation with conventional. One more stimulation protocol for poor responders is dual stimulation in the same cycle, where we stimulate the follicular phase, give a trigger, agonist trigger, and again after gap of 2 to 3 days, we again start stimulating in the luteal phase and do 2 pickups in the same cycle. This is called dual stimulation, mostly for poor responders or poor ovarian reserve patients. So to extract these which which are not recruited in the first follicular stimulation. Follicular versus luteal phase ovarian stimulation during the same menstrual cycle in a reduced ovarian reserve population results in a similar euploid blastocyst formation rate. That's the study which was published in Fertility Sterility in June 2016. And the other thing which I want to emphasize is oocyte cryopreservation. ASRM has now said that mature oocyte vitrification and warming should no longer be considered as an experimental procedure. So wherever possible, single women, elderly female, so we should always counsel them for oocyte cryopreservation. So to summarize, our aim of ovulation induction should always be induction of follicular growth, and pharmacological agents initiate, augment, or modulate the pharmacological gametogenic response of the ovary. They overcome the natural follicular selection process to increase the number and quality of oocytes available for fertilization. Before starting ovulation stimulation, we always should analyze the ovarian reserve, select the correct stimulation protocol, define the goal of your ovarian stimulation, what is your goal. Then you have to select the stimulation protocol, correct protocol depending on these factors: age, FSH, AMH, AFC, and the most important is the previous response to the treatment. As I've already mentioned you the prerequisites in the previous slide, proper history, basic investigations, detailed scan. Whenever you're starting a stimulation on day 2, you always see for the follicular any absence of ovarian cyst, follicular size should be less than 10 mm, endometrial thickness should be less than 6 mm. Then you start the ovarian stimulation. Choice based on AMH and AFC. Whenever the AMH is high, we know that it's a high response. You should always go for antagonist protocols. Normal response patients where the AMH are normal, you can always go either for agonist or antagonist protocol. When the AMH is very less, you go for a flare agonist, or the last option is oocyte donation. Ovarian response always depends on the presence of other infertility factors, genetic FSH receptor polymorphisms, past performance to the control ovarian stimulation, risk tolerance, type of stimulation regime used, and type of GnRH analog used. So, as I already discussed, if it is a non-PCO, you can either go for agonist or antagonist, but PCO, obviously, you should always think about the antagonist protocol. Yeah, thank you all for the patient listening. One point which I think I missed is use of antagonists in our timed intercourse or IUI cycles. You can always, in cases like premature LL surge, where sometimes you see a follicle of 14 and you call after 2 days and you see there is no dominant follicle. In these cases, mostly in cases with elderly females, this antagonist is doing wonders in improving the clinical pregnancy rates. You can always start antagonist along with gonadotropin, and till the follicle reaches 18 mm you can add the antagonist and then give trigger on try either natural or your IUI cycles. Thank you all for patient listening. I'm ready to take questions now.
Yeah. Thank you, ma'am. Thank you very much for your excellent and very detailed talk. It's always an honor and learning to hear you, ma'am. And ma'am, if you allow me, then we'll have a quick question and answer
Yeah,
session. Yeah, I'll read out the question for you, ma'am, from the comment box.
yeah.
Yeah. I mean, we have a question. Uh, what is your approach in poor responders?
Yes. Yeah, as I already discussed in the presentation, poor responders, we have to, like, we have the Poseidon criteria for poor responders. It depends. There we classify the poor responders depending on the age, AMH, and the most important two categories we see is the age and AMH. So AMH less, younger patient, younger female, the results are much better. At the same time, comparatively, AMH less, age is more, the response is very poor in our stimulation cycles. Definitely, I always go with the antagonist protocols in my poor responders, and I try to use HMG. Even though the Poseidon group 1 and 2 say that you can use a recombinant FSH, but my experience is using HMG will give a better result in cases of poor responders. We have to classify the poor responders into the categories: young age, better quality oocytes, we all know. elderly age with low image, poor quality usage. Yeah, definitely antagonist protocol and HMG will be my drug of choice. Yeah, and dual stimulation also we have tried in few cases where we could able to pull good number of embryos and then transfer later. Yes.
Yes, thank you, ma'am. And also, I think the second question is also related to what you've answered, whether synchronization of the follicle cohort with GnRH antagonist prior to the start of gonadotropins is effective than traditional GnRH antagonist long protocol.
Uh, can you repeat the
Can
question, please?
yeah, ma'am. Whether synchronization of the follicle cohort with GnRH antagonist prior to the start of gonadotropins is effective than the traditional GnRH antagonist long protocol.
Yes, yes. See, to synchronize the follicles, there are few things which we follow. One is giving a luteal estrogen, giving a estrogen in the luteal phase. That means we give in the later luteal phase of the previous menstrual cycle, we give estrogens, and then that will give a synchronized follicle. Yes. One more protocol, what we follow is giving antagonists for the initial 3 days and then start the stimulation. Yes, that is one of the method where we do to synchronize the follicles. Yes, we can use that. It's better when they are asynchronous follicles. We are saying few, like whenever you're doing a scan, there's some follicles around 8 very few follicles around 4. There is a asynchronous follicular picture. You can always give antagonists for the initial 3 days and then start the gonadotropin stimulation. But the one point we have to keep in our mind is whenever you're giving the antagonist, it's better you use HMG than recombinant FSH in your ovarian stimulation. Yes, that is much better whenever you see a asynchronous growth than going for a typical antagonist protocol. Yes, you can give that protocol. Initial 3 days of antagonist, but stimulation should always be with HMG, or you can always use a luteal E2 protocol as well, where you can give estrogens in the luteal phase of the premenstrually.
Thank you, ma'am. And we have one more question. Oh, what are the predictors for the success of GnRH antagonist protocol? What are the predictors for GnRH antagonist protocol?
Predictors of success is obviously, to be frank, it's the most important thing I feel is deciding the proper dose. Recruitment is very important on the day two. Predictors of success will always be your oocyte number, how many M2 oocytes you are getting, how many good quality embryos you are getting. So obviously, whenever you are it's a very, I think, the dose which we are using on day two and the recruitment of the follicle, uniform recruitment, and the number of M2s we are getting, depending. See, if I'm seeing, whenever I'm doing my stimulation, I have an idea that these many M2s I'm expecting. If I'm thinking, if I'm able to get that many M2s when I do outside retrieval, that means probably my stimulation is correct. So that's how I predict or I analyze my stimulation. So, so what quality M2 I get and how many, whether uh, if I'm thinking that I'll get 10 M2s, I should get 10 M2s during my retrieval. So that's how I analyze my stimulation, whether it is correct or the dose which I've used is correct or not.
Yeah, thank you, ma'am. And there is a appreciation message from Dr. Tulika Tripathi saying it's a great presentation.
Oh, thank you. Thank you so much. Thank you. Means a lot.
Yeah. Uh, Madam, I think I don't find any additional questions in the comment box. So
Okay.
if you allow me, then we will close this
Yeah,
webinar.
yeah, sure.
Yeah. Thank you, ma'am. Thank you for your giving your valuable time and for the excellent talk. And many thanks from the Shield team.
Yeah, thank you. Thank you, Dr. Someshwar. Thank you,
Yeah.
Prasad. And thank you, Sheil. Thank you.